Good afternoon. Welcome. We'll take a little while to allow everybody to log in. So thank you for everybody for logging in this afternoon and giving up your time. Today is going to be the Reducing Long Length of Stay Virtual Network webinar series, and today's particular topic is operational and clinical site management. And we've got a couple of guests that are going to come in and give us a presentation on that in a moment or so. In normal style, we've got a little bit of an icebreaker in a moment, and we'll roll straight into that. But I'm just looking down the list of people that have arrived, and maybe on the chat room, which you'll see situated at the bottom of your screen. You can click on it. You can say who you are and where you're from, just a way of orientating yourself and the team around you. We've got members of our team, which we'll introduce in a moment, who'll be monitoring the chat room, prompting a bit of discussion. So we'd really like you to be able to use that space to put your thoughts, your ideas, your questions. So once Annie and Andy have finished their presentation, we'll have a chance to ask them questions, and maybe we'll just scoop some of the questions from the chat room to be able to relay it to them, and they'll be able to, or they'll do their very best to answer. If they aren't able to answer, we'll, if you leave your email, we'll get in contact with you after the actual presentation. So please don't think we'll leave anything hanging. If something's a little bit tricky, we won't avoid it, but we may not have the expertise in the room to deal with it at the time. That's a bit of background. So in terms of the icebreaker today, just how are you feeling? Use the chat box to respond. How are you feeling? You might be thinking about COVID-19. You might be thinking about how busy things are right now. Just how are you feeling? You might like to use a scale of 1 to 10. 10 being particularly good. I'm about 9.2 at the moment. I don't know about anybody else. So please use that just to engage, so we're getting a feel for how you're getting on with the technology. Thanks very much for that. The next slide is the various members of the team that should be involved today. I'm looking across all of those. I won't introduce them all by name, but the top left, Aldridge and Annie Prime, are the people that are going to be presenting the focus model for us today. So I'm just checking with my colleagues on the chat room. Is there anything that we need to be aware of early doors, guys?
So the majority of people are feeling very good today. We've got mostly between 8 and 10.
Brilliant. That is absolutely lovely. So without any further ado, I'm going to introduce you to Annie Prime and Andy Aldridge.
Right, hi. So the logistics of just moving the camera around. By way of introduction, my name's Andy Aldridge. I'm an improvement manager with ECIST, the Emergency Care Improvement Support Team. And I'm a nurse by background, and part of my background is operational site management.
My name's Annie Prime. I'm also an improvement manager, an ED nurse by background, and I've held various operational roles. We're going to talk to you about the focus operational site management model today, and how it links with length of stay. This is a model that was developed with some of our ECIST colleagues who have specific expertise in clinical site management and multiple years of experience between us.
Okay, so what I'm going to do initially is just a bit of an overview of what we're going to be talking about in a little bit more detail, really. So the focus model, as Annie's just explained, was developed to give some structure to site management. We find there's a lot of variability around the country in the way site management is run. So initially we're going to talk a little bit about the front door position and triggers within site management, moving on to operational oversight and management of whole hospital constraints. And as I say, we'll do this in a little bit more detail as we go through the conversation. Following that, we'll move on to the challenging patient plans and pathways, understanding actions required and agreeing accountability, and finally, site plans, escalation, and report. One of the things we'll then do is pull it back together to talk about how this links into long length of stay.
So the F in focus, as Andy mentioned, is front door position. And part of that's knowing how you're doing, what's coming up and what issues you're going to have, what's your current performance and what's your predicted performance. Everybody needs to know how they've done yesterday and what they can improve.
Okay, really important that we, within site management, understand and have an oversight of capacity and demand. I think most people get that. what our current weights are in ED. We're specifically talking about front door position here, what our weights are in ED, what our weights are in SDEC, frailty, and our assessment areas.
So locally defined triggers is really important because every organisation is different with different demographics. Knowing what actually tips you over the edge, whether, you know, how many ambulances arrivals at one point can your department cope with, how many patients per hour, knowing your individual triggers, and that's something we've helped numerous sites to develop.
Next point, moving on to the next point, one of the things that we in ECIST often recommend within organisations is that they have internal professional standards. Really important site meetings that we understand if we've got speciality delays, where they're sitting, and what the response is to the emergency department from our specialities against our internal professional standards.
So the next part of the front door position is, are patients being assessed and have they got a plan in place to avoid 4-hour breaches? So as much as you can, looking at patients that are in your department and checking that they've got a plan if they're going to be referred. And sometimes, you know, that might mean senior staff in ED prompting some of the doctors to establish that plan and make sure it's communicated.
Okay, so clearly talking about 4-hour breaches, but we also talk about 12-hour breaches and avoiding 12-hour breaches. Really important that we're talking at an individual level what the plans are to then avoid 12-hour breaches within the department.
And I think we'll probably go on to discuss that a little bit later if we have time, because what you find in some site management is actually 12 hours is driving where the patient is placed, and then you end up getting a lot of patients in the wrong place, which impacts on their length of stay.
Yeah. So we also want to be talking about senior nurse and medical coordination in the department. Is it working for us today? Are we having agreed board rounds at agreed times? We would often recommend 2 hourly board rounds within an ED and ramping that up as it gets busier.
And ambulance arrivals and the offload position. Obviously, if you're not offloading the ambulance, you need to be up to speed. Are you offloading them in a timely way so that we can release them to get back out?
So moving on to the O then of focus, we're talking about operational oversight. So this is the piece in your site management meetings where you want to have operational oversight of the whole hospital and the constraints that exist within the hospital. So we want to know, and again, as Annie's already alluded to, we'll come back and talk a little bit about this and how it impacts on long length of stay. But our outlier position is really important. We want to know that all of our outliers have been reviewed. Have we repatriated outliers where that's possible back to their base wards, because we know that's better for patients, both from a mortality and a length of stay perspective.
So staffing is going to be an obvious one, and a very pertinent one, considering the coronavirus outbreak. Staffing is fundamental to how well your organisation can flow getting patients through. That will obviously incorporate your ITU and HTU capacity, and any escalation plans to create capacity within those areas.
Okay, we want to have an eye on tertiary referrals and repatriation positions. So, we want to be getting people back to our hospital who belong in our hospital, and vice versa, people who need repatriating to other hospitals back there. So we need to be having that conversation around those. Really important that we've got a view on infection control. I think it's really valid to have infection control represented at site management meetings. We want an up-to-date position really on side room capacity. Is often very important around flow and can increase your outlying position if you don't have that sort of capacity very rapidly. And equally, decontamination of side rooms, decontamination of bays. If we've got beds shut through infection control issues, we need to understand that and when the likelihood is that they will be reopened.
So understanding your demand and capacity for all your diagnostics, site management is looking for bottlenecks anywhere in the organisation. And it may be that if you've had a whole load of CT requests or ultrasound requests, it may be that you have to action something to undo that bottleneck.
One of the things that we often talk about in ECIST and try to get sites to implement is the red to green day approach. So a red day is when everything that could be happening today isn't happening for patients. And whilst we don't want a situation where everything is escalated to a site management meeting because it becomes absolutely unmanageable, the key stuff that the wards are really struggling to kind of unpick, the really knotty issues, those kind of red days we would want the detail of those bring into the site management meetings really, because it gives us an opportunity to either try to unpick those knotty issues in the site management meeting or make a decision within the meeting of where that would be best escalated to get the problem sorted out.
So operational oversight also includes today's actual discharges and potential discharges, and whether you and your team understand, with those potential discharges, what needs to happen to actually make that discharge happen. Is there enough transport capacity? Are pharmacy overloaded? It's having that oversight of all the potential bottlenecks.
Moving on to board rounds and ward rounds. So one of the things that we absolutely know, there's research out there on this, is that regular board and ward rounds reduces length of stay for patients. Really key. And so, as a hospital, we would want to understand what our expectation is around board and ward rounds, what time do we expect them to be completed, and then we need to put some checks in place to make sure that they're happening in a timely way, and some challenging if they're not really, to understand how we can support wards to make sure that they are happening in a timely way.
And finally, any service continuity challenges and impact on flow. I'm sure this is particularly pertinent at the moment, and everybody's out there planning their coronavirus contingency plans, but it could be a ceiling's fallen down in one of your diagnostic areas or in your outpatients, and the impact that's going to have on flow in the rest of the organisation. Site management is more than just beds.
Absolutely. So that takes us on to the next slide, which is around the C of focus, which is the challenge that we need to put in. So really important that site management meetings aren't just a description of where we are as an organisation. There also needs to be some challenge put in as to in a proactive way of where we want to be really. So we need to understand, is the capacity to assess patients in the same place as where the demand is for that requirement? So do we need to be, and what that's referring to is, do we need to, and is there an opportunity to move some of our resource around to meet the demand? And it's having that real-time oversight of what's going on in the hospital at that current time.
So I think this is probably my favourite slide, the challenge. And I think if you don't get the front door of the hospital right, it will lead to issues in the back door of the hospital. So I think part of the role is to challenge, is the patient on the right pathway? Would this patient be better served going through a same-day emergency care? Could they be seen as a day case, asking, if this patient was in an outpatient area, would I admit them? Or are you getting the patient to the right bed first time? And it's important that those decisions are challenged, especially with some junior doctors move around very, very frequently, and they're not necessarily aware of what services are available within your organisation. The nursing staff tend to be much more constant, but the site team will have oversight of what capacity is in each of those areas.
And I think the point Annie's making, the following 3 points link into that quite closely, really. So can the patient be appropriately managed in short stay? We need to maximise those opportunities, because where we miss those opportunities, they end up as long length of stay patients. So can we maximise our same-day emergency care areas to make sure that the appropriate patients are going through them, and we're turning those patients around in the day where it's possible, really. And
I think the next one's fairly self-explanatory. Has a senior person made this decision? Because, no disrespect to it, but there will be a tendency to err on the side of caution and just admit patients if that's the path of least resistance. So you need to know that a senior review has taken place in order to admit that patient.
And I think the final point I've already touched on, so I won't dwell on it too much, but I don't think you can overemphasise the fact that we need internal professional standards within organisations. What do we expect that we can achieve as a speciality, as a hospital, and are we achieving that? So, are we achieving our internal professional standards?
Understanding actions and agreeing accountability. This sounds really, really obvious, but site meetings quite often can be a load of people coming into a room and just gathering information or sharing information. They need to generate actions and actually have named people against those actions, so that actually they can be followed up and those people are accountable for delivering on those actions.
And closely linking into that, so if we're going to agree actions at the site management meeting, and we really should, we need to log those so that we know what the actions were, and we need to circulate them to the relevant teams. So the teams, we're communicating those actions out so that people know what the expectation is. Really important.
And obviously monitoring the progress and all of that fed back. Like everything, you need to close the loop. Any actions that have been delivered, fed back to the site team, so that's one less issue to be resolved.
And then I think at that point, what that allows us to do is agree our operational pressures, escalation levels, our OPAL levels, which you'll all be familiar with.
So the site plan, report and escalation. Key to any clinical site management is being proactive and not reactive. Always have a plan for the next 2 hours, 8 hours and the following day, and potentially even the following week. It's looking at what's coming over the hill, really.
Yeah, absolutely. And I think linking into the previous point that I made, really important to have clear documented actions and identify responsible colleagues who are accountable for delivering those actions. It's really important. So what we see occasionally is that there is an action, but there's a number of people who could deliver that. Actually, we want key people who are accountable for it, so that they know that it's their role to deliver those actions.
And I think importantly, once you've agreed your OPAL escalation level, each level should trigger specific actions, and it shouldn't be just in a plan that's locked away. You know, it is the responsibility to make sure all of those actions are being delivered, and it may well be that they have to be refined and reviewed regularly. It's a constant learning environment. What goes really well on one day may well need to be filtered into your plan at a later date.
And I think that then brings us to a point where, and I'm sure colleagues out there listening to this will be familiar with system-wide escalation calls. So systems will have escalation models built in as well. It's important that within the acute trust they link in closely to the system-wide escalation model so that it's supportive in nature and prompts a response where that's appropriate.
And make sure that those calls are not just an exchange of numbers, and actually you can be really specific about what you want your community partners or your CCG. What do you need from them to help you out of your escalation level?
I think that's a really important point. It's well worth systems sitting down as a system to discuss what is the purpose of our system-wide escalation call and what do we want the outputs to be. If it's just a description of where we are, often that's not a great deal of help to the acute trust.
Time.
Absolutely, because what you find is site managers will get pulled into the escalation calls more and more the busier it gets, and actually the less time site managers have to kind of be on calls at that point. So it's really important to identify the purpose of those calls and what we want the outputs to be of those calls, and they need to be meaningful. And
it's a really busy, kind of crazy job, so avoid escalitis. Be really clear when you're escalating something. Explain the situation, the background, the assessment and the recommendation using SBAR. What is it that you need to help you move on or move out of the OPAL level that you're on? So a little bit earlier on in this conversation, we talked about coming back to the outlier situation, and there's a little bit of an infographic there on the screen. I'm not going to go through the detail of the infographic because you can see it for yourself. But what it's basically highlighting is that if we outlie patients, actually average length of stay goes up, or some hospitals will call it boarding patients, outliers, boarders, same thing. But length of stay goes up quite significantly, really. Just to draw your attention to a really important point with the red circle. So if I'm a cardiology patient, for example, on a cardiology ward, we would expect my length of stay to be an appropriate length of stay. But actually, if there are other cardiology patients outlined, my length of stay will also go up as well. So it's not just the outlined patients whose length of stay goes up. Actually, it affects everybody within the speciality, a really important point. And ultimately, it's a quality experience. You know, if I've got a gastro problem, I want to be on the gastro ward with the gastro consultants and the gastro nurses who are used to looking after my condition. Absolutely. So bed modelling is absolutely fundamental. Right-sizing your organisation and your acute bed modelling. And that's all. So that bed modelling that refers to all specialities, really. And so just a brief resume
of kind of what we recommend really. So target demand management on frail, older people, system-wide, not just in the acute trust, by all means in the acute trust, but not just in the acute trust, system-wide, GPs, intermediate care homes.
Get patients to the right stream first time. It has a huge impact. Every time you move a patient, you add risk and you build in delays to that patient's length of stay. So getting it right first time, and sometimes that does mean holding your nerve, allowing a patient to go beyond 4 or 12 hours, but doing the right thing for the patient.
Consider AEC, so your same-day emergency care, your SDEC areas as the default for all stable patients. That's all specialities, so it's about having an SDEC area for each of your specialities so that those appropriate patients can go directly there and be treated there.
And your focus should always be beyond the ED and understanding your constraints, ensuring that there's early senior review on every ward, knowing which wards haven't had a senior review and actioning anything around that. Daily senior reviews and board rounds, having oversight of that. Focus on discharge, the safer patient flow bundle, simple rules, day in, day out. Red and green bed days, it's just based on the theory of constraints, understanding where the constraints are so that you can achieve flow. And ward round checklists, ensuring that everything's not batched, waiting till the end of the ward. All of these will have an impact.
And then the final slide is, it's an infographic really. It's just about having an appropriate acute medical model so that we do the appropriate thing with these patients from the outset and that we're not admitting patients into the body of the hospital who didn't really need to go there. So it's about having an ED and working to a time target of 0 to 4 hours in your ED. It's about having SDEC areas for each of your specialities and working on that time frame of 0 to 24 hours to turn those patients around. As we said in the previous slide, consider all of your patients who are stable. Are they fit to go to an SDEC area and treatable in an SDEC area? If they're not, fine. But if they are, they should be going there. And then an acute medicine unit, which works on a 0 to 72 hour basis. So 2 midnights or less is what we're going to say. So it's about having that appropriate acute medical model in place to avoid the admissions. So I think that probably draws us to a point where what we've done is we've explained the focus model and how we think good site management principles link into long length of stay and hopefully reducing long length of stay.
I was going to say, and the reason for developing it was because there is such variation between different site managers and how they manage things. But having those 5 principles, if all of your teams can adhere to those 5 principles, it should help reduce variation and understand, so ED will understand what the expectations are of them, and so will the wards.
Andy and Annie, thank you very much. We've got some questions that come through. You mentioned about the variation. Are there some places out there that you would notice, or you've noticed that there really is good practice, that you would say that they would be places that we could go and have a look at, see what they're doing?
It's really changeable. There are elements of good practice in lots of different organisations. I don't know that anywhere's perfect all of the time. No. I think some of the role of a site manager can be very personality dependent. So you can visit on one day when X is in charge and it's all quite smooth. That's why we developed the model, to try and reduce that variation.
I think that's a key point really. It is about holding on to these principles to try and absolutely reduce that variation from person to person and hospital to hospital to hone it down.
And I think I heard something there about recognising leadership within that as well.
Yeah. Absolutely.
A couple of other questions which have come through. You mentioned about refining and learning from the tool to recognise what are the next best actions, or you find ones with some unintended consequences. How do you capture that learning from, say, last weekend and re-embed it into next weekend, or what's the recommended way for capturing the learning?
So I think you touched on there, Rob, about the leadership. It is about having your site management team with really good leadership and putting good governance structures in place for the site management team so that you not only capture the learning. So to use your example, if we had an issue last weekend, we capture that, we discuss it as a site management team. If it involves other divisions, we discuss it with divisions and introduce it into their governance structure. So I think it's key. The site management team, as Annie said, it's a very difficult job. partly because it covers the whole hospital. So those links into divisional governance structures where it's appropriate, to take the learning back to individual divisions, individual departments where necessary, I think is really key. So I think the leadership of the site management team is more than just organising the site management team, as it were. It's about having those links into the wider hospital so that we carry the learning together forwards together.
It's hugely about communication. You know, there's no, you know, listening to your colleagues that will have other ideas and different approaches. You know, like everything we do in medicine, everything's evolving.
Yeah. With regards to that, thank you. It might be useful to ask people via the chat room if they know of a site that's got good site management, and perhaps feed that back to the wider group here. That'd be really handy. Have you got any top?
So is that an ask you're putting out
to the people that are on the call right now? So maybe they can feed us. I've certainly seen some good stuff at BHR, UCLH, and they even use the focus.
Salford is another very good site. There's some good site management principles.
And so you have your standard operating procedure, and you will, you know, constantly review that, develop that. Different situations arise. You learn from those and amend it, and use the people and the knowledge around you to keep that regularly under review. But if you've got your standard operating procedure, then everybody knows at least what the basic expectations are of them and what their roles within the team are.
And without putting words in your mouth, you've got a review mechanism within that, so you can capture the learning systematically as you're going through. Have you got any top tips for developing internal professional standards?
Top tips. My top tip, I guess, would be in terms of implementing them anyway, they definitely need to be understood by all staff. They need to come out from your nursing, medical director and your COO, and all of those people need to be signed up to them. And I would say there needs to be a level of accountability. There's no good having internal professional standards if nobody is held to account for when they breach them, or if indeed there are no consequences for not attempting to achieve what the agreed standards are.
I think my answer to that question, Rob, would be it's really important that they're developed internally. So occasionally what you'll see is that we borrow internal professional standards from another site and try and implement them. I'd really avoid that if I was you. I'd develop them with your specialities, ask your specialities what they believe their internal professional standards should be. Very often you'll find they can be quite challenging on themselves. They want to be, you know, so developing them with your specialities rather than implementing somebody else's model, I would definitely recommend.
Brilliant. I'm just about to read a question out directly from the chat room. What short-term actions can an organisation take to manage surges in demand and release capacity in a particular speciality without having to resort to boarding?
So I think this is about it's about a multitude of things, but I think if we honed in on, this is about, it can't just be the site management team that create capacity. The site management team rarely create capacity. They manage the capacity that is created by the divisions. And it has to go back to divisional level. It has to go back to our clinical directors, speaking to the doctors within the team to look at, you know, what can we do today to release, you know, some capacity within the organisation. That capacity then has to be handed over to site management to be managed in the most appropriate way.
And I think it's thinking about areas within your organisation, perhaps. I think I've heard it described as elastic walls. Is there an area that's appropriate for patients that will, you know, adhere to all of their privacy and dignity, that you can actually perhaps open for a short period and then close again later, and making sure that appropriate patients are placed in that area, perhaps to relieve congestion in another area?
So and on that point, really, I think it's a good point. De-escalating is just as important as escalating. So de-escalating those areas back down again and getting the organisation back to normality, really important. That it's done as quickly safely, but as quickly as possible.
And that's, again, reiterating the point, is about selecting the right sort of patients to go in that area.
So I just got a question. It's one of the questions that I've asked recently by one of the staff on the wall, well, in the hospital, and that was, you know, sometimes you kind of go on duty and you kind of go, oh, we're going to be good this weekend because X is on, and how, you know, I know we talked about internal professional standards, but how, you know, in reality, how can we really help staff to get that it doesn't matter who's on, we're always the same, and how we can support staff. Any words of advice?
I just think it's ultimately about supporting people, developing people, and no, everybody will have different strengths and different weaknesses, and actually understanding those, and understanding we've all got some strong points and not so bad, and then if you can try and amend your rota so that you've actually got a combination of X and Y. So that you've got the strengths and weaknesses. We've all got bits. None of us are perfect.
I think it's really important, isn't it, to understand that you'll always have variability within teams because you've got different experience levels and all sorts of things that come to play on that, really. But I think Annie made the point earlier, this is where the internal professional standards piece comes in. Lots of organisations will put internal professional standards in place. It's about monitoring those internal professional standards and picking up and supporting people where maybe we're not achieving them. And I do mean supporting. So often people will want to do the right thing, they may need some support to achieve it.
So yes, absolutely. So thank you. The other thing that we talked about was doing reflection, and actually as a team doing after action. So. Review. So thank you. That's really helpful.
A lot of chat on the chat room about the power of being proactive and not react to the situation, getting your plans ahead for the next 4 hours. I can't remember the rhythm that you described.
4, 8, 12, and potentially even the next week and the next season.
Yeah, so it's almost like a constant re-refining of the rhythm of the site with the rhythm of the wards, with the rhythm of the system.
we know that things change. We know that demand is increasing. It's almost having that understanding, information and oversight. Is your demand changing in minors or for respiratory patients? It's constantly under review and keeping that oversight.
I think it's important to bear in mind that very often urgent care is at least as predictable as planned care. Very often, and it's having that kind of data. Some of it's quite simple data. I know lots of sites out there will work on a 6-week rolling average for example, for discharges and admissions. It's powerful data. It's very, very useful data to have.
Is that predictive modelling of some description? Would you say?
Yeah, absolutely. Yeah. Absolutely.
And is there anywhere that does that well, would you say?
I think there are a number of sites that use the 6-week model to predict what's going to be coming through the doors. You can use that same basis for how many discharges we have, for example, on a Friday in respiratory, for example. Because I think it's really important, isn't it? If we know how many discharges on a 6-week average, you may get a little bit of variability, but often it's fairly accurate. But if we're talking to our ward managers about that, then we know what kind of discharges we're looking for on those days.
And I think most organisations, their business intelligence can produce that. It's really, really important that it's locally produced. You can't pick this off a shelf. There are tools that you can buy, that you can bring into your organisation, but it's really important that it's done locally for you. And even for the organisation that's 5 miles down the road, it will not be the same.
Okay, lovely. Can I say thank you to Andy and Annie for your time today and going through that. Just one little call back out to the chat room, if I may, just to invite any last-minute questions.
So there are quite a lot of questions, and that have been put in the chat room, and what we'll probably do is kind of look at them afterwards and post them on our NHS Future site, which hopefully everybody that's joined today are aware of the Future site. And there's a great discussions already building on there. So we'll carry on some of those discussions on that site afterwards. So thank you.
Thank you very much.
Thank you.
And just to wrap up, just a big thank you to all of the people involved today with regards to bringing this, and mostly to the people that have given up their middle of their days to attend. Thank you. Could I just point you towards the feedback form, because we'd like to make them more reflective of your needs, and we'll keep on making sure that we develop these in line with what you need. So without any further ado.
And just a reminder about next week's session. So if you could just move the slides on, because my memory's not that good. So that's thank you. And there we go. Next week's session is managing risk, and really hope that people will be able to join that session. And then these are the sessions that have been designed by you or for what you have requested. So we've got managing risk next week, and then we've got safer, red to green, on the 19th of March, and then on the 26th I'm really excited, I'm excited about all of them, but the 26th is going to be really different, and we're going to be looking at leadership behaviour. So, not quite sure what that will entail, but we'll be having some outside speakers to help us with that session. So, should be a really good, exciting session. So again, as always, please ideas that you have for future sessions, just shout. Tell us what you would like us to help you with. Thank you.